Chapter 50, page 881, Introduction to the Renal System. Now you have to know all the key terms, but there are some key terms if I were you, I have to pay special attention to. You need to know them. Aldosterone, okay? Aldosterone, this is a hormone produced by the adrenal gland. Remember those adrenal glands, they sit right on top of your kidneys. You take your two hands like this, you go behind your back, where your palms are, those are where your kidneys sit, right? The adrenal glands are those two triangular shaped glands right on top of your kidneys. So aldosterone is a hormone produced by the adrenal gland that causes the distal tubule to retain, to hold on to sodium and therefore water while losing potassium into the urine. That's important to understand. So aldosterone, which is a hormone, it makes you hold on to sodium. Well, what follows sodium? Water. So you're holding on to the sodium, you're holding on to the fluid, but you're getting rid of potassium. ADH, anti-diuretic hormone. Well, we know diuresis is what makes you urinate. So if it's anti-diuretic hormone, it makes you hold on to all those fluids, right? Reabsorption. You guys have to understand the difference between reabsorption and resorption. That one letter, the A, will completely change a test question. So to reabsorb is to take back in, to hold on to. Resorption, without that A, without that extra A, is to let go. All right, towards the bottom here. So the renal system, the system has four major functions in the body: maintaining the volume, clearing nitrogenous waste. And so what happens is, guys, all of the bad stuff that you don't need in your body, that you don't need in the blood, once that blood gets to the kidneys filter it out. And it takes all of those toxins, all of those nitrogenous waste, and it should come out in the urine, right? And the rest of the clean blood goes back to the body. What else does it do? It maintains acid-base balance and electrolytes. I think you guys learned about that last semester in fundamentals, right? Remember, the kidneys are responsible for what? Bicarb, your H2O3, HCO3. Regulating vitamin D activation. And that's important. By the way, guys, this is also recorded on the live, so you guys can go back anytime. But vitamin D is important because you need vitamin D to absorb what? Anyone know? Calcium. Yes, you can take as much calcium as you want, but if you can't absorb it, what's the point? So you need that vitamin D in order to absorb calcium. It regulates blood pressure. And that makes sense because guess what? If those kidneys shut down and nothing's getting past that bad boy, you're holding on to all these fluids, your blood pressure is going to go up, right? And on the opposite end of the spectrum, if your kidney's letting everything fly, you're losing all of your fluids. What happens to your blood pressure? It goes down, right? And regulating RBC production, and that's through the secretion of erythropoietin. That's what makes those baby RBCs. So kidneys do a lot. Let's jump to page 886, key points. All of this stuff is A and P. You should have learned it already, so I'm not going to go over all of it again. Let's take a look at the key points on page 886, important things to remember. The kidneys play a key role. Again, guys, everything I just mentioned about retaining, regulating body fluid, maintaining blood pressure, RBC production because of the erythropoietin, acid-base balance, electrolyte stability. When the renin, angiotensin, aldosterone system is activated, it's activated when the blood flow to the nephron is decreased and renin is released. So think about it. If blood flow to the nephron is decreased, right? Follow me here. Renin is released. The end result is increased vasoconstriction. What happens when we have these blood vessels start to squeeze? Does the blood pressure go up or down? Up. Up. So that's how it helps also regulate the blood pressure. You see what's happening? Vasoconstriction, which causes increased blood pressure, and sodium and water retention. Guess what sodium and water retention also does? Increases blood pressure. Why? I want you to think about blood pressure in this way. All blood pressure is is the force that's being exerted against the vessel walls. That's all blood pressure is, the amount of force that's being pushed against those walls. So it makes sense, the more fluid you have, the more blood you have, the more force that's going to be pushing against those vessels, hence the higher the blood pressure is going to go. Okay? And then blood volume and blood pressures increase. Next, red blood cell production. Again, guys, it's controlled by erythropoietin. This is the second time we're seeing it. And I skipped a whole bunch of pages, right? So most likely they talked about this 2, 3, 4 other times. That's important for you to know. Erythropoietin stimulates bone marrow to produce RBCs. Remember, your bone marrow, that's what makes your red blood cells. That's what makes your white blood cells. That's what makes your platelets. So the kidney has an active role in stimulating your bone marrow to make RBCs. Guess what? The more RBCs you have, right, the more fuller your blood vessel is. The fuller your blood vessel is, more force is being pressed against those vessels. Key points on page 887. You also need to know this. So the female has a shorter urethra than the male. So think about it. If it's shorter, that's just a shorter distance that pathogens and bacteria will have to travel to get to the bladder. So who do you think would be more at risk for UTIs? Women. Okay. The shorter female urethra leads to leads from the urinary bladder to the outer body into the area rich in gram-negative bacteria. Let me tell you something. Above the belt, this is your belt line, right? Above the belt tends to be gram-positive bacteria. So patients who have pneumonia or strep throat or upper respiratory infection, we tend to give them antibiotics that kills gram-positive bacteria, because things that are above the belt tend to be gram-positive, but things that are below the belt tend to be gram-negative. Okay, you guys learned about that in micro. Cystitis, or infection of the urinary bladder, is common for women, and it makes sense because their urethra is so much shorter. Those bacteria and pathogens really don't have a long way to go to get to the bladder. The longer male urethra passes through the prostate gland, which may enlarge or become infected, a problem that's often associated with advancing age. Page 888. Summary. Look at this. How many times have we seen in this book that they told us what kidney plays a key role in? 1,000,000 times. Make sure you guys take a look at the summary. Diuretic agents, chapter 51. I'm on page 890. Your first drug card I want from you are going to be your Thiazide Diuretics. That's drug card number 1. So Thiazide Diuretics, that's actually the drug class. And these drugs you see here fall under that drug class. So your chlorothiazide, your hydrochlorothiazide, your methylchlorothiazide, those fall under the Thiazide Diuretics. So what you're going to do is, on your drug card, you're going to write Thiazide Diuretics, that's the drug class. And then you can give me these medications, just write it under, so I know that you know these medications fall under Thiazide Diuretics. Okay? That's your first. The second one, I don't know why I don't have this highlighted, because I sure do need it from you. My second one I need from you are the loop diuretics. And make sure under loop diuretics, you write down these drugs. Put a star next to furosemide, because when it comes to loop diuretics, furosemide is the one they ask the most about on NCLEX and tests like ATI, HESI. Yes.
Is it okay if I turn off the lights?
Absolutely. Go ahead. My third drug card I want from you, potassium sparing diuretics. And when you write all these drugs that fall under potassium sparing diuretics, go ahead and put a star next to the spironolactone. That's the drug that they use the most on exams. Now, guys, besides your exam that I write, I don't write these exams. I don't write HESI, HESI, NCLEX. So everything is free game. I'm just letting you know which ones tend to show up the most. So that's 1, 2, 3. All right, my fourth drug card, Osmotic Diuretics. That's easy because you only have one drug for that, mannitol. All right, page 891. Diuretic agents are commonly thought of Diuretic agents are commonly thought of simply as drugs that increase the amount of urine produced by the kidneys. But the greater clinical significance of diuretics is their ability to increase sodium excretion. The fact that diuretics make you get rid of sodium, page 891. The fact that diuretics make you get rid of sodium, that's how you get rid of the fluids, because the fluids follow the sodium. Everyone there, page 891? Okay. Diuretics are indicated for the treatment of edema. You know what edema is. What's edema, guys? Swelling, yes. Edema associated with heart failure, acute pulmonary edema, liver disease, including cirrhosis, renal disease, and for the treatment of hypertension. All of conditions that we need to get rid of the fluid. Patients got too much fluid in their body. They're also used to decrease fluid pressure in the eye. That's your intraocular pressure, which is useful in treating glaucoma. And that's what glaucoma is, increased pressure in the eyeball. Diuretics that decrease potassium levels may also be indicated in the treatment of conditions such as hyperkalemia. So if a patient has too much potassium, which is your hyperkalemia, you guys know normal therapeutic range of potassium is 3.5 to 5. That is a very narrow therapeutic range. Anything out of that, patient can have some serious heart issues. It can even cause death. So if a patient has too much potassium and they also happen to have too much fluid, it would make sense for us to give them a diuretic that, yes, gets rid of the fluid, but also gets rid of the potassium, right? Loop diuretics make you lose potassium. Okay. Diuretics. Diuretic classes include the thiazide and thiazide-like diuretics, the loop diuretics, your carbonic anhydrase inhibitors, potassium-sparing diuretics, and osmotic diuretics. And we're going to cover all of those. The most common adverse effects seen with diuretics include GI upset, fluid and electrolyte imbalance, hypotension, and electrolyte disturbances. So let's talk about that for a second. Yes, when it comes to those diuretics, remember, a patient's getting rid of all the fluid. It's coming out of the bladder. They may have a stomach uneasiness, diarrhea, constipation, nausea, all those GI upsets. But more important than that, fluid and electrolyte imbalances, because along with all that urine that they're losing is sodium, sometimes potassium, chloride, right? So that can cause electrolyte imbalance. Hypotension, you're getting rid of all your fluid. As the fluid goes down, so does the pressure that's being exerted against the vessel walls, right? So yes, it makes sense that we would see patients' blood pressure go down and electrolyte disturbances. Key points. Diuretics increase sodium what? What's that word? Excretion. Do not get confused, because as students, I see you do this all the time. You will see diuretics increase sodium, and you just ignore that word excretion. That can trick you. You need to pay attention. So yes, it increases the excretion. So at the end of the day, are you holding on to the sodium or getting rid of it? Getting rid of it. Okay, they help relieve edema associated with heart failure, pulmonary edema, etc. So let's start with thiazide diuretic. This is the first class of drugs we're going to cover. Thiazide diuretics, they belong to a chemical class of drugs called the sulfonamides. Let's jump to page 895. Thiazide diuretics include, and here's a list of all of the drugs that fall under the thiazide diuretics. My pronunciation is horrible. I'm not even going to go through all of them. Make sure you take a look at them. However, those drugs that are on page 890 that actually fall in the drug class, those are the ones I definitely want to see on your drug card. Okay, but you need to know all of these drugs that fall under that class, because the way this book is set up, it teaches you about the drug actions and the contraindications and nursing interventions by drug class, not by the drug by itself, because many drugs fall into a class. So you don't only have to know those drug classes, you have to know what drugs fall under that class. Because on the exam, I may give you a test question about a drug class, and then your very next question will be about a drug. And you would have to know what class that drug falls under. So let's talk about the therapeutic actions and indications of the thiazide diuretics. I'm not reading all of this, so let me just tell you what all of this is trying to say to you. The therapeutic actions and indications of the thiazide diuretics is to prevent the reabsorption of chloride and sodium, to prevent the body from taking back up chloride and sodium. Okay, I'm going to jump all the way down here. Look what it says. These drugs are the first line drugs used to manage essential hypertension when drug therapy is needed. Ding, ding, ding. First line. Do I have first line on my list of words you need to know when you're studying? You need to pay attention to? No?
Yeah, first.
First? No, that's not enough. We have first, but first line. First line, as in golden standard. So a patient has hypertension. The very first drug class we expect the physician to order for that patient is going to be thiazide diuretic.
He said stop the body from reabsorbing sodium
and chloride. Because remember, as the body gets rid of chloride and especially sodium, the fluid follows. So we get their blood pressure to go down just by getting rid of all that fluid, because remember, it's a fluid that's pressing against those vessels that's making the blood pressure go high, right? Pharmacokinetics, I usually don't go over those, but when I do, you're going to see it on a test somewhere. So for this, I'm not going to cover the pharmacokinetics. You really don't need to know it. I shouldn't say you really don't need to know it, because you need to know everything in this book. I don't write the NCLEX. However, I'm going to skip that. You guys can read that on your own. Let's go to contraindications and cautions for the thiazide diuretics. First and foremost, obviously, guys, if we're giving a thiazide diuretic, are we going to give it to a patient that's allergic to thiazides? No. Remember, the thiazide diuretics come from the sulfonamide family. So are we going to give it to a patient that's allergic to sulfonamides? No. You are not robots. So I don't care what the doctor, you saw what just happened over at Vanderbilt. I don't care what the doctor orders. If there's a contraindication, are you going to give it, or are you going to hold that med and place a phone call to the doctor, say, hey, I know you ordered this, but the patient has an allergy. You're going to hold it. And if that physician or nurse practitioner or physician assistant tells you to give that drug anyway, you tell them to come down and give it themselves, because you're not going to lose your license. And let me tell you something, when you are a nurse that knows their stuff, the minute you call them and tell them something's wrong, they're going to be like, okay, don't give it, I'll change it, or they'll do something else. Do not put your license on the risk, at risk for anyone. So we're not going to give thiazide diuretics to anyone that's allergic to thiazides or allergic to sulfonamides, because remember, the thiazides come from the sulfonamide family. We're not going to give thiazide diuretics to anyone that has fluid and electrolyte imbalance. Think about it. One of the things that thiazide diuretics can cause is fluid and electrolyte imbalance, obviously, because you're getting rid of fluids, you're getting rid of electrolytes such as the chloride and sodium. So why would you give something like this to a patient that already has fluid and electrolyte imbalance? You want to make it worse? You want to give them exacerbation? No, so that's also contraindicated. Yes, sir.
What if the patient have high chloride, high sodium? Can you give them?
Absolutely. If the patient has high chloride, high sodium, and they have hypertension, they're full of fluids, the doctor orders it, you can give it that. When I say imbalance, I mean like already low. Severe renal disease, because these thiazide diuretics, all diuretics actually, they make what work harder? The kidneys. So the patient already has renal disease, that's kidney disease. You think they can handle this type of drug? Absolutely not. All right, you got caution. Caution should be used with patients who have lupus. Let me tell you something. Patients with lupus, you guys are taking med surg right now as well? Okay, so you're going to learn about lupus soon. One of the organs that end up failing for patients with lupus, and many patients with lupus end up dying from this, which is end-stage renal disease. Their kidneys just give out. And we just learned that these diuretics are very, very hard on the kidney. We're not going to give it to anyone with kidney disease. So you definitely need to be cautious of patients who have lupus, that we know them having lupus alone puts their kidneys at risk, right? Glucose tolerance abnormalities or diabetes, which is worsened by the glucose elevating effects of many diuretics. You're getting rid of all that fluid, that sugar staying and being concentrated, and can make the patient with diabetes become even worse because the blood glucose goes higher. Gout, liver disease, hyperparathyroidism, bipolar disorder, pregnancy, lactation if they're breastfeeding, because those meds can go through the breast milk. Adverse effects. Let's talk about the adverse effects of thiazide diuretics. GI upsets, fluid and electrolyte imbalance, hypotension, electrolyte disturbances. This has to be the 5th time, this line right here, that we've seen this about thiazide diuretics. You better bet your bottom dollar you're going to see it on the test. Okay? Adverse effects associated with the use of thiazide and thiazide-like diuretics are related to interference with the normal regulatory mechanisms of the nephron, which is located in the kidney. It can cause hypokalemia, which makes sense because as the patient's getting rid of all this fluid in the urine, the sodium's in the urine, guess what also comes out in urine? Potassium. Okay, it can lead to hypokalemia. Signs and symptoms of hypokalemia. You need to know this. You're going to see it on the test. What are they? Weakness, muscle cramps, arrhythmias. Remember, your normal potassium range is 3.5 to 5. Another adverse effect is decreased calcium excretion, which leads to increased calcium levels in the blood. Decreased calcium excretion. That means you're not getting rid of calcium the way you should be getting rid of calcium. So guess what? You're holding on to the calcium, but here's the problem. You're holding on to the calcium. It's not like you're holding on to the calcium in your bones where your bones get stronger. No, you're holding on to the calcium in your blood. So now you have hypercalcemia, okay? Uric acid excretion is also decreased because the thiazides interfere with the secretory mechanisms. High levels of uric acid can cause gout. And guys, it makes sense because if you go back to the contraindications right here, gout is a contraindication. Now you know why. When you're taking thiazide diuretics, if you're a patient that already has gout, oh my gosh, thiazide diuretics makes you hold on to that uric acid, which make that gout even worse. If these drugs are used over a prolonged period, blood glucose levels may increase. And I already explained to you why. You're getting rid of all this fluid, but not the glucose. That glucose becomes concentrated, and you start to see those glucose levels go up. Urine is slightly alkalinized when the thiazides or thiazide-like diuretics are used. What can this lead to? UTI. Think about it. The urine is supposed to be acidic, and that acidic environment is what keeps the bladder nice and healthy, because bacteria and pathogens do not like acidic environments. That's number one. And number two, when the bladder is acidic, those bacteria, they can't stick to the lining of the bladder when it's an acidic environment. So when you urinate, those pathogens have no choice but to be flushed out with the urine because it can't stick to the lining of the bladder when it's an acidic environment. But the patient is taking thiazide diuretics, It makes that urine more alkalinized. So it's easier for the pathogens to stick to the lining of the bladder, and it makes it easier for those pathogens to actually survive in that type of environment. So that puts the patient at risk for UTIs. Drug-drug interactions. I cannot pronounce, you guys get used to it. I can't pronounce for the life of me. Cholestyramine or cholesterol. If this combination is used, the drug should be taken separated by at least 2 hours. So those two drugs, your cholestyramine or cholesterol, if you have to take that and you have to take a thiazide diuretics, you have to separate them by at least 2 hours. Do not give them at the same time. Page 897. This is on NCLEX. It's been seen many times. Make sure you know it. The risk of digoxin toxicity increases due to potential changes in potassium levels. Let me say that again. The risk of dig toxicity goes up due to the potential changes of the potassium level. Serum potassium should be monitored if this combination is used. So if you have a patient that has, cardiac dysrhythmia, they have some issues, they're taking digoxin, right? But they also have to be on a thiazide diuretic, you better be checking that potassium level, making sure that's within range. Risk of quinidine toxicity increases due to decreased quinidine excretion. So you're not getting rid of that drug and it builds up in the body and the patient can get toxic levels of it with an alkaline urine. And we already know that thiazide diuretics cause the urine to become more alkalinic, right, than acidic, leading to increased serum levels of quinidine. Quinidine is not a drug that you want to have a toxic level of in your body. You will have some serious cardiac dysrhythmias. If this combination is used, if the patient has to take quinidine, but they're also taking thiazide diuretics, the patient must be monitored closely and quinidine dose decreased as appropriate. Why? We want to make sure that they don't get toxic levels in their body. Decreased effectiveness of anti-diabetic agents may occur related to changes in glucose metabolism. We know that when the patient is taking thiazide diuretics, there's a chance of their glucose going higher or lower? Higher, which makes the diabetes worse. Did you guys notice how already, just in these 2 pages, they've told us in 3 different ways that thiazide diuretics messes with their glucose and makes the glucose increase? This is what I mean when I say when you notice repeating information, that means it's going to be a test somewhere. Stop. Say to yourself, this is important. The author of this book, in 2 pages, they told us the same thing in 3 different ways. They use different words, but they're still telling us the same thing, the same outcome. The risk of lithium toxicity may be increased if these drugs are combined. So if a patient's taking lithium, maybe they have maybe they have psychotic issues, they're bipolar, whatever. They're taking lithium, but at the same time, they have to also take thiazide diuretics. They can have lithium toxicity, and lithium toxicity also is deadly. So the serum levels should be monitored. Normal serum levels 0.6 to 1.2. Okay.
Tell me please what page.
Oh, this is page 897. Next, oh, by the way, guys, I give you a 10-minute break every hour because I know this is a lot of information. So at 10:40, I'll give you guys a 10-minute break, okay? Just hang with me. Let's talk about loop diuretics. Loop diuretics makes you lose potassium, okay? Loop diuretics are so named because they work in the loop of Henle. Loop diuretics are also referred to as high ceiling diuretics because they cause a greater degree of diuresis than other diuretics. 4 loop diuretics are, and they give you the list, make sure you know them, especially make sure you know your furosemide, your Lasix, that makes you lose potassium, and it's a loop diuretic. Therapeutic actions and indications. Why would we give loop diuretics? Loop diuretics are the Drug of choice. Do we have drug of choice on our list? Nope. Let me add it. When you see drug of choice, baby, you better know that's important. You're going to see it on test somewhere. Drug of choice. Drug of choice is another way of saying first line. It's another way of saying golden standard. It's another way of saying first. Okay? Don't say I didn't warn you. Look what it says. It says loop diuretics. I'm all in the wrong place. Loop diuretics is the drug of choice when a rapid and extensive diuresis is needed. So let's go back. The thiazide diuretics were our drug of choice when the patient was hypertensive and we want to get it down, right? But if there's an acute situation going down and we need to get that fluid out of their body fast, what are we going to give them? We're going to give them the loop diuretics. Again, when you want a rapid and extensive diuresis. Oh. In cases of severe, I'm tired of going up there. Can you go write that word severe up there for me, please? Thank you. In cases of severe edema or acute pulmonary edema, put severe and put acute. Let me explain to you why. The author could have just said edema, right? They could have just said, where were we? They could have just said pulmonary edema. There's a reason they put that descriptive word before they put edema. They said severe edema. That's another way of them reminding you that we give the loop when it's really bad. Otherwise, we could have just given them a thiazide diuretic, right? Does that make sense? That's the author's way of reminding you that we're giving the loop when we need to get rid of it now. Something's going on with that patient right now. We need it right now. We don't have time to wait. So it says in cases of severe edema, and it would make sense if the patient had severe edema that we need rapid and extensive diuresis, right? Because edema is severe. So cases of severe edema or acute pulmonary edema. Are patients ever supposed to have fluids in the lungs? No. But we've had patients with pulmonary edema and it's chronic and we're maintaining it, right? But that word acute, the word acute means something that just happened, it's going on right now. We need to address it right now. When you see that word acute, when you're reading, you need to stop and say, whoa, this is important. You see that word severe. For example, if you're a nurse working on the floor and the LPN comes to you and says, hey, you know, patient in room 100 says they have a headache, and you say, okay, I'll come check on them, and you expect the doctor to order an analgesic like a Tylenol, acetaminophen, right? But that same situation, and they say the patient said they have a severe headache. Whatever you were doing, you better drop it and go back to that patient. Severe, that just changed that headache to possibly stroke and other issues. When you see severe, that patient has now become a priority, okay? Anyway, it's important to remember that these drugs can have an effect only on the blood that reaches the nephrons. I know I have only on the list, don't I? You guys see that? Oh, this won't let me be great. So yes, the loop diuretics, this is a great class of drugs, but look what it says. It works only on the blood that actually reaches the nephrons. If a person is not able to perfuse the kidney because of heart failure or vascular disease, guess what? The drug's not going to work. Why? This drug only works on the blood that can get to the nephron. So if the patient has decreased perfusion, what does perfusion mean? Perfusion is the ability of the body to actually use those resources, use up the oxygen, the vitamins, the nutrients, the minerals that are in the blood, okay? That's what perfusion is. So if the patient's perfusion is decreased, the drug's not going to work because only the blood that can get to the nephron will be effective, okay? Let me make bigger for you. Loop diuretics are commonly indicated for the treatment of what kind of heart failure? Acute heart failure. Because remember, when it comes to loop diuretics, we're giving them in severe cases where we need to get that diuresis going right away. We don't have any time. Okay, so we give it in cases of acute heart failure, acute pulmonary edema associated with heart failure or with renal disease and hypertension, but not any type of hypertension. It's got to be really bad hypertension where we don't have time to get it down in a couple of days. We need to get that blood pressure down immediately. Okay. Next page, page 898. Are your brains fried or you can wait till 10:40? Okay. Contraindications and cautions. Obviously, if the patient has any allergies to loop diuretics, we're not going to give it. If the patient has electrolyte depletion, we're not going to give it. Think about it. Imagine a patient has a potassium of 3. Would you give a loop diuretic to that type of patient? No, because their potassium's already low, and we know that loop diuretics make you lose potassium. Are we trying to kill our patient? Absolutely not. So patients with electrolyte depletion, we're not going to give loop diuretics to. Patients with severe renal failure, we're not going to give it to because it's not going to work. Remember, only the blood that reaches the nephron. So if they have severe renal failure, that drug is not going to work for that patient. Routine use during pregnancy is not appropriate. You're not going to give it to women who are pregnant. You're not going to give it to patients who have lupus because remember, that diagnosis of lupus by itself places that patient at risk for kidney dysfunction. Okay. Glucose intolerance, glucose tolerance abnormalities, diabetes mellitus, gout, for the same reasons of thiazide diuretics. All of those are contraindications. Page 900. Safety for use in children younger than 18 years of age hasn't been established. If one of these drugs is used for a child, we're talking about the loop diuretics. If we have to give it to a child, careful monitoring of the child's fluid and electrolyte balance is needed, and emergency support measures should be on standby because it's much easier for an adult's body to recover than a child's. A children will go down quickly on you. Adverse effects. What are the adverse effects of loop diuretics? Number 1, hypokalemia. That is on NCLEX. Make sure you know it. Alkalosis. Remember, your normal pH is 7.35 to 7.45, right? Loop diuretics increase that pH. It makes you more alkalinic. Okay, so alkalosis is an adverse effect of the loop diuretics. Hypocalcemia and tetany. Why? Think about it. Patients getting loop diuretics, they're losing electrolytes in the urine, including calcium, right? So you lose calcium, that's what causes a hypocalcemia. What's the sign of hypocalcemia? Tetany, right? You see patient having Trophtek sign where you touch your cheek and they go like this, right? Or Trousseau sign where you take their blood pressure and their hands start spazzing. That muscle and nerve irritation happens because of low calcium. That's your hypocalcemia. Okay? Excuse me. Excuse me. The rapid loss of fluid can result in hypotension and dizziness. Let's stop there for a second. What does that tell me? This tells me that if I give a loop diuretic to a patient, I have to watch out for overcorrecting the problem because they could have had hypertension, right? I give them loop diuretic, but I overcorrected the problem. Now they have low blood pressure. And along with that low blood pressure comes orthostatic hypotension, dizziness. That patient's at risk for what? Falls. So you're going to have, well, let me not get into that. We'll get into nursing interventions in a minute. But you better have some fall preventions, right? Make sure you get that patient up slowly, make sure they dangle, all that good stuff. Long-term use of the loop diuretics can result in hypertension Glycemia because of diuretic effect on blood glucose levels. How many times have we seen this? So susceptible patients need to be monitored for this effect. Who are the susceptible patients? Patients who are diabetic or even pre-diabetic. We better be checking their blood glucose. Remember, normal blood glucose is 70 to 110. Ototoxicity and even deafness have been reported with these drugs. Drug-drug interactions. The risk of ototoxicity increases if loop diuretics are combined with aminoglycosides or cisplatin. So if that patient is taking aminoglycosides or they're taking cisplatin, they can have problems with hearing, ototoxicity. They may even lose their hearing, so we have to be careful. Anticoagulation effects may increase if the drugs are given with anticoagulants. Well, what do anticoagulants do? They keep your blood from clotting. So if, look what it said, it says anticoagulant effects may increase if they're given with loop diuretics. This patient is at risk for bleeding out if we give them with loop diuretics. We don't want our patient hemorrhaging to death. So we're going to be watching them and looking at their skin, making sure they're not bruising easily. We're going to tell them to make sure when they brush their teeth, they report any pink tint sputum, which means they probably have blood coming up from their gums, right? We're going to teach them when they urinate or they defecate to check the stool and check the urine to make sure they're not bleeding through the urine or through the stool, right? Because we know that if they're taking anticoagulants while they're taking loop diuretics, there is a chance that they can bleed out. There may be decreased loss of sodium and decreased antihypertensive effects if these drugs are combined with, let me stop before I even give you the drugs. Look at what it's saying. Because remember, we're giving loop diuretics to lower the blood pressure. We're giving loop diuretics, we're getting rid of those electrolytes through the urine. But look what it says here. It says there could be a decreased loss of sodium, decreased antihypertensive effects if we give these drugs with indomethacin, ibuprofen, salicylates, or other NSAIDs. So these drugs that I just mentioned, if we give those drugs with the loop diuretics, it's going to decrease the effectiveness of the loop diuretic. The loop diuretic is not even going to give what it was supposed to give, which is what? Lowering that blood pressure. It decreases the effectiveness of it, guys. A patient receiving this combination should be monitored closely. Highlight that list: indomethacin, ibuprofen, salicylates, or other NSAIDs. If the patient takes those with loop diuretics, the blood pressure may not go down the way we expect it to, and we may not get rid of those electrolytes such as the sodium, such as the chloride, such as the potassium, the way we expect it to. Okay? Next, carbonic anhydrase inhibitors. These are the drugs that fall under that class. Make sure you know them. Therapeutic indications. Oh, by the way, when it comes to testing, the drug that I've seen they've asked the most when it comes to the carbonic anhydrase inhibitors is your Diamox, acetazolamide. But make sure you know all of them. Like I said, I don't write NCLEX. But that Diamox is the one, if they ask about this drug class, that's the one they usually use in their question. All right, therapeutic actions and indications. Why would we give this class of drugs? More sodium and bicarb are lost in the urine. These drugs are used as adjuncts to other diuretics when a more intense diuresis is needed. So let's stop there. Look at what this just said to you. And I know, guys, you may find me to be annoying because I'll read something and then I'll explain it again. Let me tell you why I'm doing that. Because as students, I notice this is what you do. You just read and read and read and read, and you never even stop to be like, wait a minute, what did this just say to me? Just what you see I'm doing, that's how you're supposed to study. It's going to take forever, but trust me, that's the difference between an A and seeing your way out of this nursing program. Okay? So look what it says. More sodium and bicarb is lost in the urine. Okay, more sodium is lost in the urine. We've been seeing that with the diuretics, but also bicarb. What we've been seeing with the diuretics thus far is us having an alkalinic environment. And we know that bicarb supports this alkalinic environment, right? But now we're seeing that bicarb can be lost in the urine, causing the urine to be more what? Acidic. This is where your critical thinking comes in, because they didn't say it to us. I'm sure they're going to say it like somewhere down the road, but I want you to catch things like that. All right. These drugs are used as adjuncts to other diuretics. So you saw the thiazide diuretics, we were giving it, that's our first line treatment for the patient with uncomplicated hypertension by itself. The loop diuretics, if we have an acute situation, we need to get that diuresis going right away. We need extensive diuresis. We would give the loop diuretics by itself. But the carbonic anhydrase inhibitors, we give them as adjunct. We give them as an addition to another drug if that other drug is not as effective. Yes, sir.
If I'm losing the bicarbonate urine, should that make my urine more alkaline?
What is bicarb? Is bicarb?
Alkaline.
Exactly. So if you're losing the alkaline, what would your urine be?
Should be more alkaline. I'm losing it. I'm not keeping it in the blood. I'm losing it in the urine.
Listen, you're absolutely right. You're losing it in the urine, but it still will cause that, it still will cause that urine to become more acidic. Initially, it may become more basic, but I'm telling you, it will cause that urine to end up being more acidic. Not acidic to the point that we don't have to worry about, I'm sorry?
Long term.
Yes, exactly, long term. I'm not talking about acutely, I'm saying long term. And not extensively to the point where we don't have to worry about UTIs anymore. However, it does decrease that pH long term. I forgot what I was saying though. Oh, yes. With this one, they give it as adjunct, as a helper to another drug if that drug is not being as effective. Thank you. Okay, most often, excuse me, carbonic anhydrase inhibitors are used to treat glaucoma. Remember glaucoma, that's that increased pressure in the eye. It's used to treat glaucoma because the inhibition of carbonic anhydrase results in decreased secretion of aqueous humor of the eye. And here's why you have that glaucoma. That aqueous humor is not being released, that fluid, so it's increase, and it increases the pressure in the eye. So this is a wonderful drug to treat glaucoma. Did I mention this? Results in decrease. Okay, we talked about that. So let's talk about contraindications and cautions. When would we not give this class of medications? Obviously, if there's an allergy to any carbonic anhydrase inhibitors, allergy to the drug, or to antibacterial sulfonamides or thiazides. Why? It says to prevent hypersensitivity reactions, or in patients with chronic non-congestive and angle closure glaucoma. Routine use during pregnancy is not appropriate. If you can't remember, because there are a lot of drugs, let's say you can't remember, to be safe, we don't want to give during pregnancy or breastfeeding. There are some drugs that are safe, but most of the drugs we don't want to give during pregnancy or breastfeeding. So if you can't remember, just go by that rule of thumb. We're not going to give it to patients who have fluid or electrolyte imbalance. Adverse effects: metabolic acidosis, hypokalemia, paresthesia, that's that tingling that you're feeling of the extremities, confusion, drowsiness, drug-drug interactions. There may be increased excretion of salicylates and lithium if they're combined with these drugs. Caution should be used to monitor serum levels of patients taking lithium. Just like potassium has a very narrow therapeutic range, lithium has a very narrow therapeutic range, 0.6 to 1.2. Once you hit 1.4 or 1.5, whichever your book says, you're already at toxic level, okay? So look, when the patient is taking salicylates or lithium, excretion of this drug can be increased. Diuretics. These diuretics are used for patients who are high risk for hypokalemia associated with diuretic use. such as patients receiving digitalis or patients with cardiac arrhythmias. Let me back up, guys, because I completely skipped something. Let me back up. Potassium sparing diuretics. This is what we've moved on to. So potassium sparing diuretics, we give those drugs for patients who are at risk for hypokalemia. And think about it, potassium sparing. What does sparing mean? To hold on to, right? So if you're giving a diuretic that spares potassium, it makes the patient hold on to potassium. So doesn't it make sense that we would give this type of drug to a patient that has hypokalemia? Their potassium's already low, so whatever little bit of potassium they have left, we want them to hold on to it. We don't want them to lose it in the urine. So I'm going to repeat it where it says these diuretics are used for patients who are high risk for hypokalemia associated with diuretic use. And they give you examples, patients receiving digitalis or patients with cardiac dysrhythmias. Therapeutic actions and indications. So what do the potassium sparing diuretics do? Why would we give them? Potassium sparing diuretics cause a loss of sodium while promoting the retention, of potassium. And you guys know that sodium, potassium, they go opposite ways. Spironolactone, that S in spironolactone stands for sparing. Spironolactone is a potassium sparing diuretic, okay? Spironolactone acts as an aldosterone antagonist. Remember that word antagonist means to work against? It works as an aldosterone antagonist, blocking the action of aldosterone in the distal tubule. Potassium sparing diuretics are often used as adjuncts with thiazide or loop diuretics in patients who are especially at risk if hypokalemia develops, such as patients taking antiarrhythmics or digoxin, and those who have particular neurological conditions. That's the second time we're seeing this. So we have a patient that has to have these diuretics, and whether they were taking, thiazide or loops, it caused them to be hypokalemic or even at risk for hypokalemia. This is where your potassium sparing diuretics come in. Spironolactone, the most frequently prescribed of these drugs is the drug of choice. It is a drug of choice for treating hyperaldosteronism, a condition seen in cirrhosis of the liver and nephrotic syndrome. You need to know that. Contraindications and cautions. When would we not give the potassium sparing diuretic? To any patient that has an allergy to potassium sparing diuretics, any patient that's hyperkalemic. Think about it. Potassium sparing diuretics makes you hold on to potassium. If that patient has a potassium of 5.1, are you going to give this? No, because we know potassium therapeutic level is 3.5 to 5. We don't want to throw them into hyperkalemia. We don't want to give them cardiac dysrhythmias. So that's going to be contraindicated. Patients with renal disease and urea, they're not urinating at all. Routine use, again, during pregnancy is not appropriate. And I put a little NCLEX next to the hyperkalemia because NCLEX has asked about this a lot in the past. They expect you to know, to recognize if a patient's hyperkalemic, you're going to withhold that medication. So usually what they'll do is, they'll give you a situation, they give you the labs, and, they'll sneak in that potassium. The potassium will be right in the middle of all the other labs. And they expect you to recognize the potassium is supposed to be 3.5 to 5. And if it's more than 5, we're going to withhold that medication, call the physician, let them know that, hey, this potassium's high. What do you want to do? And they better not say give it anyway. Adverse effects of potassium sparing diuretics. You see what I wrote here? Know these. I will kill you on the test with them. Adverse effects, hyperkalemia, of course, because it makes you hold on to potassium. We might overcorrect the problem, right? Yeah, we wanted them to hold on to potassium, but now we overcorrected it. Now they got hyperkalemia. That definitely is an adverse effect. Hyperkalemia, which can cause lethargy, confusion, ataxia, ataxia when they're walking like they're drunk, ataxia, muscle cramps, and cardiac, page 902, cardiac arrhythmias. Look what I put next to it, NCLEX. By the way, guys, when I'm doing lecture and I'm going over this stuff and I tell you this has been seen on NCLEX. You see I put a star next to it that says NCLEX. What do you think I'm going to put on your test? NCLEX stuff. My whole purpose is for you, by the time you're done with this program and you go take your NCLEX, boom, 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 boom. You're not sitting in that testing room for hours and hours. You get out and you pass. But this is how you're supposed to study, to train your mind to do that. Patients taking these drugs need to be evaluated regularly for signs of increased potassium and informed about the signs and symptoms to watch out for. You have to teach a patient those signs and symptoms of hyperkalemia. It's not enough that you keep checking their potassium levels, but you have to teach them those signs and symptoms to report as well. They should be advised to avoid, do I have the word avoid up there, guys? Okay, avoid foods that are high in potassium. NCLEX loves asking about this, and they usually select all that applies. So you need to know this box. Foods that are high in potassium. I did you the favor of highlighting the ones that show up the most on NCLEX, but I don't write NCLEX. They could change it any day, right? Avocados, tomatoes, watermelon, oranges, grapefruit. They used to have banana on their line. They stopped because everyone knows banana now, but banana, okay? Make sure you guys take a look at this. Broccoli, cantaloupe. Because these drugs work much like aldosterone, they're associated with various androgen effects, such as androgen, guys, those are your like sex hormones, okay? Such as hirsutism, women having facial hair. Gynecomastia, men having the man boobs, right? Deepening of the voice and irregular menses. All of this you need to know. Drug-drug interactions. We're almost done with this part. Let me finish up and I'll let you guys take a 10-minute break. Drug-drug interactions. The diuretic effect decreases if potassium-sparing diuretics are combined with salicylates. If a patient is on salicylates and they're also taking potassium-sparing diuretics, those potassium-sparing diuretics will not work as well. Okay, guys, take a 10-minute break. When you come back, we will start on osmotic diuretics. Okay, osmotic diuretics. Osmotic diuretics, I'm on page 902. Osmotic diuretics pull water into the renal tubule. Look at this, without sodium loss. All these other diuretics we've been talking about, sodium's coming out in the urine, right? But with the osmotic diuretics, that's what makes it stand apart. When you're studying, this is how I want you to read. I want you to say to yourself, wait, this is different than everybody else. Guess what? The oddball, you always need to know it. What makes it stand out? So it pulls water out of the renal tubule without sodium loss. And the great thing about the osmotic diuretics, you only have one, mannitol, okay? Therapeutic actions and indications. It pulls fluid into the vascular system from the extravascular spaces, including aqueous humor. Therefore, mannitol is often used in acute situations when it's necessary to decrease the intraocular pressure, before eye surgery, or during acute attacks of glaucoma. So let's stop right there. It just said to us, guys, that it decreases fluid, including aqueous humor. And we know that glaucoma, the patient has too much aqueous humor, causes too much pressure in the eye. So this is also a great medication to bring down that pressure. It's also the diuretic of choice, drug of choice in cases of increased intracranial pressure or acute renal failure due to shock, drug overdose, or trauma. Well, that's interesting because those other drugs we learned about, a contraindication was kidney failure, right? But look at this osmotic diuretic, We give it for glaucoma. We give it for cerebral edema or increased cerebral pressure, or even acute renal failure. And I put a little thing next to it. NCLEX, you need to know that it's a drug of choice for these conditions, and usually on NCLEX, it's a select all that applies. Pharmacokinetics, I think it's the first time today that I've gone over the pharmacokinetics with you. I don't go over them often, but when I do, that means you need to know it. It's seen on NCLEX. Mannitol is the only, there goes a key word, it is the only available drug given for IV use. Mannitol is only available for IV use. Contraindications and cautions. When would we not give it? Mannitol is contraindicated patients with renal disease and anuria from severe renal disease, pulmonary congestion, intracranial bleeding, not pressure, intracranial bleeding. Make sure you read carefully when you're testing, dehydration, and heart failure. Again, routine use during pregnancy is not appropriate. Adverse effects. Make sure you know them. Remember, guys, mannitol, we give it for extreme cases, right? It's given how? IV. You guys know that the route that makes a drug be absorbed the quickest is IV route, okay? Sudden drop in fluid levels. That's very important. So you know that patient that's getting mannitol, we're going to be very concerned with safety, right? Because their blood pressure dropped like that. Sudden drop in fluid levels. By the way, that word sudden, when you're testing, and usually they'll give you a situation about patient and then it says suddenly, and whatever comes after that word suddenly, if there's a decrease in that patient status, 99.9% of the time, that's the patient you're going to run to see. You know those situations where they ask you, which patient would you go to first? And they give you these different situations. When you see that word suddenly, and then whatever falls behind the suddenly, it's a decrease in their situation, that's your answer. Anyway, nausea, vomiting, hypotension, lightheadedness, confusion, and headache can be accompanied by cardiac decompensation and even shock. Remember, all of your organs need perfusion for them to work. All of your organs need the oxygen, the vitamin, the nutrients, the minerals that are found in the blood, right? So I want you to think about it. If we give this mannitol and it causes a sudden drop in those fluid levels, what do you think can also suddenly happen? Those organs can start to fail if they're not being perfused, because those oxygen, vitamins, nutrients, minerals that we find in the blood, we find in the fluid, are being lost in the urine. Fast and quickly, that's the same thing. Quickly, okay? Patients receiving mannitol should be closely monitored for fluid and electrolyte imbalance. All right, nursing consideration for the patients receiving diuretics, all of the diuretics. What are our nursing considerations going to be? We're going to make sure they don't have any allergies to the thiazides, sulfonamides, fluid. They don't have fluid electrolyte disturbances. They don't have gout. They don't have glucose tolerance abnormalities, liver disease, lupus, hyperparathyroidism because of that calcium. They're not pregnant. They're not breastfeeding. We're going to make sure we do a physical assessment on that patient. We're going to inspect the skin fully and note the extent and degree of any edema, including evidence of pitting. We're going to assess their cardiopulmonary status, including taking their blood pressure, listening to the heart sounds, listening to the lungs, making sure we don't hear fluid in the lungs. We're going to obtain accurate body weight. Let me stop right there. The number one way to assess a patient's fluid retention is not INO. It's not skin turgor, it's daily weights. You hear me? Daily weights. We're going to obtain accurate body weight. We're going to weigh that patient, same time each day, same type of clothing on the same scale. You're going to do their INO, you're going to check their voiding patterns, you're going to check their, evaluate the liver status. So we're going to be looking at those liver function tests. We're going to be looking at the AST. We're going to be looking at the ALT. We're going to look at the lab tests, especially potassium, because the patient's at risk for hypokalemia. Unless they're taking a potassium sparing diuretic, then they're at risk for hyperkalemia. And we're going to be looking at calcium because the patient's at risk for hypokalemia because of all the calcium that they'll be losing in the urine. We're going to be checking their uric acid levels because we know with these diuretics, the patient can have increased levels of uric acid that can make the gout worse. We're going to be looking at glucose levels because we know with these diuretics, it can make that glucose concentrated. We can see the glucose levels increase and the patient can have hyperglycemia, right? We're going to check the renal and liver function test. I already explained the liver function test, the renal function test. You're going to be looking at the BUN. You're going to be looking at the creatinine. You're going to be looking at the glomerular filtration rate. Implementation and rationale. You're going to teach a patient to take the drug with food or milk to buffer the drug effects on the stomach. If GI upsets a problem, always, and that's across the board with pharmacology. If patient has GI upset with the medication, you teach them to take it with food. Not so much with milk. The milk part is just for this, but across the board, GI problems, you tell them to take it with food. You're going to administer, first of all, mannitol. The only way mannitol is given is how? IV. Administer IV diuretics how? Slowly. You're going to administer it slowly. We want to prevent changes in the fluid and electrolyte imbalance. Continue to monitor the urinary output, the patient's cardiac response, the heart rhythm of patients receiving IV diuretics, because remember, it gets rid of those fluids and electrolytes very quickly. We have to be very careful. You want to administer oral form early in the day so that increased urination will not interfere with sleep. That's on NCLEX. You need to know that. Why would you give a patient a diuretic at nighttime where they're going to get them a million times in the night to go urinate? They're sleepy, so they might fall. It's all your fault. Give it to them in the morning when they're awake. They have all day to get rid of that fluid so they can sleep at night. And we don't have to worry about them getting up confused and breaking a hip. Page 904. Monitor patient's response to the drug. You're going to check their blood pressure, urinary output, their weight, their serum electrolytes. You're going to check their hydration status, period blood glucose monitoring. Assess weight daily to evaluate fluid balance. That is the #1 way to evaluate fluid balance. I'm telling you again, it's not INO and it's not skin turgor. It is daily weights. You want to check their skin turgor. You want to assess edematous area for changes, including a decrease in the amount or degree of pitting. You want to provide comfort measures, including skin care, nutrition consultation. Provide a potassium-rich or potassium-low diet as necessary. So if that patient is on potassium-sparing diuretics, which means they're going to be holding on to their potassium, does it make a good idea to give them potassium-rich diet? No. We don't want them to go into hyperkalemia. And if we give them something like a loop diuretic, where we're making them lose potassium, right? It makes sense that we would want to give them foods high in potassium because they're going to be losing that potassium through their urine. So that's what they mean by that. Additional patient teaching. Teach them the importance of taking diuretics early in the day to avoid interference with sleep. Well, that's interesting. Didn't they just say that to us on the other page? And now we're seeing it again. Need to weigh oneself daily and report any increase in weight of 3 pounds or more in one day. That 3 pounds, you really think that's food? No, that's fluid. So it's very important. You're going to tell them to weigh themselves every day in the morning at the same time, same clothes, same scale. Importance of maintaining adequate fluid intake to prevent fluid rebound. And that word rebound, you're going to see that a lot in pharmacology. And what we see happen is whatever we were trying to do, if we did it too much, the body's going to try to save itself and you'll see an opposite effect. So we're trying to get rid of the fluid and it worked a little bit too well. And now this patient's holding on to fluid. Okay. So we want to avoid that. Need to have readily available access to bathroom facilities because they're on diuretics. They're going to need to urinate all the time. Teach them the signs and symptoms of adverse effects, including hypokalemia, which remember I told you, you need to know those signs and symptoms of hypokalemia, hyperkalemia, and hypercalcemia. Teach them to move slowly if dizziness occurs. Avoid hot environments. Think about it. First of all, you're on diuretics, you're losing fluids, you may be dizzy, you're in a hot environment, you start to what? Sweat. And now you're losing sodium through your sweat. So you teach them to avoid hot environments and other situations, potentially leading to extra loss of fluids. I'm sorry? Oh, sorry. Dietary sources of foods high in potassium with an emphasis on the need for intake these foods or the need to avoid these foods if using potassium sparing diuretics. So it all depends on the type of diuretic the patient is on that you tell them to eat foods high in diuretics, to eat foods high in potassium or stay away from foods high in potassium. Just depends on the type of diuretic that the patient is on. You're going to monitor for adverse effects, such as, how many times have we seen this, guys? Electrolyte imbalance, orthostatic hypotension, rebound edema, hyperglycemia, increased uric acid levels, acid-base disturbances, and dizziness. From this right here, I can make 10 questions, 10 test questions. Summary, diuretics, they increase the excretion of sodium and therefore water in the kidneys. Thiazides are frequently used by themselves or in combination with other drugs to treat hypertension. They're considered to be mild diuretics. And here's the thing, guys, in nursing and medicine, we always want to go from least invasive to most invasive. We always want to go from mild to moderate to severe. So we always want to start off the softest. We don't go hardcore unless there is an acute situation, okay? Next, loop diuretics work in the loop of Henle. They lead to a loss of water, sodium, and potassium. These drugs are most potent diuretics, and they're used in acute situations, as well as in chronic conditions that are not responsive to milder diuretics. Well, take a look at this. Look at what it says. Conditions that are not responsive to milder diuretics. Do you see how the author just let us know that if it's a chronic condition, we're going to try what kind of diuretic first? A milder diuretic. They just said it to us over here. Now they're saying it to us down here. And then we saw that a couple pages ago when we were learning about the thiazide diuretics. So that's 3 situations where the author is letting you know if it's not an acute situation, our first line drug of choice is going to be the thiazide diuretics. This is how I want you to look at things when you're studying, okay? Carbonic anhydrase inhibitors. These drugs can cause an alkaline urine and loss of bicarb and loss of give me a second. And loss of the bicarbonate buffer. Listen, if I had the time, I would get speech therapy. I just don't have the time. I get excited talking about this and I can't speak. You guys will get used to it. Carbonic anhydrase inhibitors are used in combination with other diuretics when stronger diuresis is needed. Remember, we give them adjunct, okay? They're kind of like the helpers. They're frequently used to treat glaucoma because they decrease the amount of aqueous humor produced in the eye. Whenever I need to scroll down, just let me know, guys, because I'm looking at the book, so I don't know that you can't see what I'm pointing to. Potassium sparing diuretics are mild diuretics. They're preferable if potassium loss could be detrimental to a patient's cardiac or neuromuscular condition. Remember, potassium acts on the muscles. What is your heart? It's a huge muscle, right? Be careful not to become, the patient must be careful not to become hyperkalemic while taking these drugs. The osmotic diuretic mannitol uses hypertonic pull to remove fluid from the intravascular spaces and deliver large amounts of water into the renal tubules. There's a danger of a sudden change of fluid volume and massive fluid loss with this drug. Why? Remember, we're giving it IV. And that's why we don't give this drug unless it's an acute situation and patients got like cerebral edema. There's something going on that we need to get this fluid out immediately. This is not our first or even second go-to drug, okay? This drug's used to decrease intracranial pressure, treat glaucoma, and help push toxic substances through the kidney. All right, that's your chapter 51. Let's move on to chapter 52, drugs affecting the urinary tract and the bladder.
I have a question.
Yes, ma'am.
So for the drug card, you gave us 5 so far,
Uh-huh.
right? Okay. 'cause I missed it.
Yeah, you're 5. I'm about to give you the 6 in a second, but let's go over these key terms. You need to know all of them.
I have only
It's
4.
4? Let me check.
Because you didn't say carbonic and.
No. Thiazide is 1. Loop is 2. Potassium sparing diuretics is 4. Osmotic diuretics 2, 3, 4. Sorry. Osmotic diuretics is
So
4.
not the carbonic.
No, you need to know that for testing,
Yeah, yeah.
but not for drug cards. So we're at 4 so far. All right, key terms. Acidification, that's making the bladder an undesirable place for bacteria. Remember, I told you that bacteria does not like acidic environments. They cannot survive in acidic environments. I'm on page 907, and they can't stick to the lining of the bladder wall. So we want to promote an acidic environment, right? Cystitis, cis, bladder, itis, inflammation of. So cystitis is inflammation of the bladder that's caused by infection or irritation. Pyelonephritis, that's inflammation of the pelvis of the kidney, and is frequently caused by backward flow problems or by bacteria ascending, that means to crawl up, ascending the ureter. So the patient may have had a urinary tract infection or urine that's just been sitting there in the bladder, and something's happening, and that bacteria creeps up from the bladder to the ureters to go up to the kidneys. So that's your pyelonephritis. All right, drug card number 5, urinary tract anti-infectives. That's your 5th drug card. And I put stars next to these 3 that tend to show up the most for testing. For urinary tract anti-infectives, make sure you recognize all of them. You want me to try to pronounce them?
Is it just the last 3?
The last 3, the nitrofurantoin, your trimethoprim, and your TMS. I'm not even gonna try to pronounce it. You see it.
So each medication will be 1.
No. You put all of these on one drug card. You don't have to do a drug card for each. That's why I'm telling you, on the first thing on your drug card, you're going to put the class. So for example, this is your 5th drug card. You're going to write urinary tract infections and write all of them down on that one drug card. But if I were you, just as a reminder that these are the 3 that they tend to ask more on testing, I put a star, just something, just for your personal way of remembering. But you don't have to do one for each, just one drug card for that class.
Do you have
For
an
each.
example?
I
You
don't.
have to find it now, but like, just so we know.
Let me write one very quickly. I thought I had a notepad.
Here, I have one.
Okay, so very simple. And next week it's going to be your first time. You're going to suck. I'm telling you now, it's going to be horrible. And that's fine. No, that's fine. As the weeks go on, you're going to learn what's important. You're going to learn how to pull out what's important in the book. So this is your drug card. Card goes this way, right? So here you're going to write drug class, whatever that drug class is. So urinary tract anti-infectives, right? And then right under drug class, you're going to write the name, right? Then you're going to give me adverse, you're going to write adverse reaction. And then you're going to give me the list. What can happen? Diarrhea, nausea, blah, 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 hypertension, blah, blah, blah. Then you're gonna give me nursing interventions. And remember, nursing interventions, I want at least, I think your outline says 2, 3, but listen, don't give me any BS nursing interventions. I want you to give me some good nursing interventions. Give me some good nursing interventions. And like I said, you're gonna suck at the beginning, but you're gonna get better. But anyway, you're gonna give me your 3 nursing interventions. Then you're gonna give me, what else do I want from you? What's that?
This is action.
Drug action. And that, just tell me what the drug does. It doesn't have to be a big paragraph. Just get to the point. What does the drug do? What else do I want from you? Ranges. When I'm teaching you, I'll let you know, because there are some drugs you absolutely have to know the range for them, and I'll let you know. Otherwise, if I don't mention it, you don't have to put it on the drug card. What else do I want from you? Therapeutic action. So you're just gonna write therapeutic action and just give me a therapeutic action. It doesn't have to be a big paragraph. It could be 1 sentence. What does the drug do? Adverse reaction, we have that. Do we have contraindications? Then you just write on that card, contraindications, and then list the most important ones. So for example, guys, let's say you're gonna give me 5 contraindications, right? That's a bad example, what I was gonna tell you. Let's go back to adverse reactions. Everybody gets nausea. Everybody gets diarrhea. Everybody, nausea, vomiting. Don't give me those. Give me some adverse reactions that you actually need to do something serious about. Give me adverse reactions such as dizziness. And your nursing intervention is going to be what? Make sure you dangle them. Make sure that you have safety precautions. If an adverse reaction is seizures, you're going to make sure that you decrease stimulation. You want to make sure you have dim lighting. You want to make sure that the side rails are padded. You see what I'm saying? Yes, you can give something for nausea and vomiting, but my point is everyone gets nausea and vomiting. Don't put that on your drug card unless there's some drugs like for testing purposes, that actually is going to be your answer, because nausea and vomiting is usually never the answer because it's everything. You know what I mean? But there are certain drugs that's going to be your answer, and I'll let you guys know when we get there. Pharmacological what?
Say therapeutic and then pharmacological.
That's whatever she said.
Yeah, I know.
That was the one you talked about.
Yes, I don't know.
And then for the name of them, we only put the name that you like highlighted.
Just what I showed you. So what you see here, just give me the class and these drugs on that list.
All of them.
And yes, all of them.
And then generic and trade name.
No, you don't even have to go into the generic and trade name. Just give me what you see on this list. So for example, if I told you I want the urinary tract anti-infectives, just write these drugs on the drug book and know that these drugs fall under the anti-infectives, because that's how I'm going to give you for testing. And so that leads me to another point. Your best bet when you're making these drug cards are to use your textbook instead of your drug book. And the reason for that is when you use your drug book, I'm going to slash it because there's so many things that are in your drug book. They're correct. However, for testing purposes, what's in this book is more correct. And I want you to think in that line. The drug book goes just way deeper, and it's so much information you're going to get lost in it, where this is really to the point and it's going to be easier for you guys to understand. Because I don't want you to give me information just to give me information. I want you to give me information that you understand, that when you get a test, you're able to take that knowledge that you have up here and transcribe it on the exam. And the drug book just, in my experience with you guys as students, it doesn't do that. You guys can know the information and you do horribly on the exams. But once I start forcing my students to only use this book, their grades just skyrocketed. So I suggest you could use a drug book if you want, but I suggest you use your textbook. All right, guys. Number 5 is your urinary tract anti-infectives. Number 6. Number 6 is going to be urinary antispasmodics. Under urinary antispasmodics, I want you to put anticholinergics because they're anticholinergics, and this is your list of anticholinergics. This is the one drug under anticholinergics that when you're being questioned about urinary tract antispasmodics, they ask about, and that's that oxybutynin. Make sure you know it. Make sure you recognize that this is an anticholinergic, and it's also used as a urinary tract antispasmodic. Okay, so that's 5, 6. Number 7, urinary tract analgesics. Phenazopridine. You need to know that. Matter of fact, this one has been seen on NCLEX so many times, I don't know why I didn't write that down. You need to understand that this is an analgesic. It is not an antibiotic. What number is that?
7.
Good, 7. Number 8, your bladder protectant, this medication, pentosan polysulfate sodium. Remember how I told you that creating an acidic environment protects the lining of the bladder so that the bacteria can't stick to it? Well, this medication protects that lining of the bladder. We'll talk about that. That was number 7?
That's 8.
That was 8? Okay. Number 9 are alpha adrenergic blockers, especially these last two, tamsulosin and terazosin. And number 10, your 10th drug card is going to be drugs that block testosterone production. Okay. All right. Page 908. Everyone there? Okay. Patients with indwelling catheters or intermittent catheterizations often develop bladder infections or cystitis. Guys, anytime you're introducing something foreign into the body, excuse me, there's also a risk of introducing bacteria. So it makes sense that patients who are getting indwelling catheters are at risk for bladder infections because you're introducing a foreign object into the body. And with that foreign object can come pathogens. Blockage anywhere in the urinary tract can lead to a backflow. That's that urine creeping up, or that those pathogens creeping up from the bladder up to the kidney, and can spread. And the spread of bladder infection into the kidneys, that's what's known as pyelonephritis. So you have cystitis, which is inflammation of the bladder that comes from infection. Then you have pyelonephritis. That's infection of the upper urinary tract that comes from pathogens that creep up down from the bladder and creep up to the kidneys. Okay? The signs and symptoms of urinary tract infection are uncomfortable, and they include urinary frequency, urgency, burning on urination, that's associated with the cystitis, the bladder infection. Look at this, guys. Chills, fever, flank pain, and tenderness is associated with pyelonephritis. You need to know the difference. You need to know the difference in the signs and symptoms of your cystitis versus your pyelonephritis. So in older adults, the only ding, that's one of our words, right? The only presentation may be confusion, disorientation, and other CNS effects. Let me explain this to you guys. The elderly, the geriatric population, they do not present the same manifestations that normal, healthy, regular adults do when it comes to infection. If you're caring for an older patient and they've always been awake, alert, oriented ×3, and all of a sudden they think they see their grandma flying across the room, the first thing you need to be thinking is infection, okay? Because very often with that geriatric population, we don't see their temperature go up. Those normal manifestations of infection that we would see, we don't see that with them. We usually see confusion. That's like one of the first symptoms that we see with them. Drugs used to treat urinary tract and bladder problems, you need to know them. So for infection, the drug of choice are going to be your urinary tract anti-infectives. And you see, I put NCLEX next to these two. Your nitrofurantoin and your TMS, these two are most, that's what they ask about the most on NCLEX when it comes to the urinary tract anti-infectives. For overactive bladder, the drug of choice is a beta-3 adrenergic agonist. For bladder spasms, antispasmodics. For pain, urinary tract analgesics, and right here you saw I put NCLEX for the phenylzopridine. By the way, again, this medication is an it's analgesic. It is not an antibiotic. It is not an anti-infective. Okay, so for pain, we can give a urinary tract analgesic, may give a bladder protectant. For BPH, benign prostatic hyperplasia, drug of choice, or drug class, I should say, alpha adrenergic blocker, or testosterone inhibitors. Make sure you guys know this table. So let's talk about urinary tract anti-infectives. Urinary tract anti-infectives are of two types. One type comprises of the antibiotics, which are especially effective against gram-negative bacteria. That makes sense because remember, above the belt tends to be gram-positive, and below the belt tends to be gram-negative. That makes sense. That causes most UTIs, and they give you those medications. Make sure you take a look at them. The other type of urinary tract anti-infectives works to acidify the urine, killing bacteria that might be in the bladder, and they give you those meds. Make sure you take a look at those. Therapeutic actions and indications. Urinary tract anti-infectives act specifically within the urinary tract to destroy bacteria, either through direct antibiotic effect or through acidification of the urine. Those are the two ways. They do not generally have an antibiotic effect systemically, so it works locally in that bladder. These drugs, those drugs with an antibiotic effect interfere with reproduction of gram-negative bacteria and cause bacterial cell death. Look at figure 52.1, sites of actions of drugs acting on the urinary tract. So make sure you guys take a look at this. Table 52.2. Something I'm going to bring to your attention, the methylene blue, make sure you teach the patient to take that with a full glass of water. What were we on for a second, guys? Oh, urinary tract anti-infectives. All right, page 911. Methenamine's been established, has established those guidelines for children and comes in a suspension form. I feel like I'm missing something. I covered pharmacokinetics. Okay, we're still on the anti-infectives. Contraindications and allergy and cautions. Any known allergy we're not going to give to the patient if the patient has renal dysfunction, pregnancy, lactation. Let's talk about adverse effects. Adverse effects associated with these drugs include nausea, vomiting, diarrhea, anorexia, bladder irritation, and dysuria. Infrequent symptoms. So these are symptoms the patient may get, but we don't see it too often. Pruritus, urticaria, headache, dizziness, nervousness, and confusion. Methylene blue can stain the skin if the skin comes in contact with it. That's important to know. Before I go into the nursing considerations for the urinary tract infections, let's look at this case study real quick. I'm not going to go over all of it, but page 910. The situation, JK is a 6-year-old girl with a history of repeated UTIs. The doctor orders methanamine. What are you going to teach a patient parents? You're going to teach always wipe from front to back. Why? We don't want to introduce bacteria from the anal area, the rectum into the vagina. So you're going to teach to always wipe from front to back, and never's up on my list, isn't it? Is never up there? Good. Never from back to front, and to avoid the introduction of intestinal bacteria in the urethra. That's why you're always wiping from front to back. Avoid baths, especially bubble baths, which facilitate the entry of bacteria into the urethra on the bubbles. You guys see this? Teach them to wear dry cotton underwear to discourage bacterial growth. Why? Cotton what? It absorbs. Okay? Patient education should also stress the importance of avoiding alkaline ash foods, such as, guys, when you're studying and they give you examples, let me tell you what those examples are. Those are your next select all that apply on the test. Pay attention. What are those examples? Citrus fruits, certain vegetables, and acids and encouraging foods that acidify the urine, such as what? Cranberry juice. Okay, it helps prevent the bacteria from adhering to, from sticking to the bladder wall. Fluid intake, especially water, should be encouraged as much as possible to keep the bladder flushed. Why don't we say fluid intake including juice? Well, let me tell you why. Juice is full of sugar. Bacteria loves wet, moist, dark, sugary environments. That's why we're saying water. Okay? Teach a patient to complete the full course of medication prescribed and do not stop taking the drugs even when you feel better. You have to teach them that if they do not take that full course of medication, that infection can come back worse, and be resistant. More patient teaching. Avoid foods that alkaline the urine. Again, such as citrus fruits and milk. Cranberry juice is one juice that can be used. Avoid using any over-the-counter medications that contain sodium bicarb. Here's an example. And acids. Another example. Both baking soda. Stay away from them. Teach them to take the full course of medication. Common adverse effects. Common adverse effects of this drug may include upset stomach, nausea. Taking the drug with food or eating small frequent meals can help. For painful urination, if this occurs, report it to your healthcare provider. A dose adjustment may be needed. If the patient's on this anti-infective and they're still having dysuria, that painful urination, they need to report it because maybe the dosage needs to be increased. Report any of the following to your healthcare provider. Here's the list, guys. Skin rash or itching, severe GI upset that prevents adequate fluid intake, and very painful urination, and pregnancy in older female patients. The following can help decrease urinary tract infections. You have to know them. What are they? Avoiding bubble baths, voiding whenever you feel the urge. Teach them the minute they feel they need to void, do so. Don't let that urine just sit in the bladder, giving bacteria perfect medium to grow. Always wipe from front to back, never from back to front. Limit alkaline ash foods such as citrus juices, and avoid the use of antacids, and tell the doctor, nurse, or healthcare provider involved in your care that you're taking this drug. So let's look at the nursing considerations for patients taking anti-infectives. I'm on page 912. You're going to test them for any allergy to antibiotics or anti-infectives, liver or renal dysfunction. Are they pregnant or breastfeeding? You're going to assess urinary elimination patterns, including the amount and episodes of frequency. And for complaints of frequency, urgency, pain, difficulty voiding, you're going to monitor their lab results. Implementation rationale.
Please slow down.
Oh, sorry. This is all repeated information. You good? Can I keep going? Not sure? All right. What'd you say?
We're good.
Okay. Implementation rationale. You want to ensure that culture and sensitivity tests are performed before therapy begins. Let me tell you something. Doesn't make any sense that we're going to give the patient anti-infective before we go ahead and do that CNS. No, because that anti-infective that we just gave them is going to affect the result of that culture and sensitivity. We need the culture and sensitivity. We're going to get that culture first, right? So when we look at that report, we can see what that patient's going to be sensitive to, so we can give it to them. So you're always going to get that before you give them the medication. You're going to administer drugs with food to decrease GI effects. Institute safety precautions if the patient experiences CNS effects such as, dizziness. You're going to teach the patient to take the full course of the medication. Tell them don't stop taking it. Even if they feel better, they have to take the whole thing. Drink lots of fluids, especially what? Water. If they want to drink something that tastes a little sweet, what can they drink? Cranberry juice. Very good. Avoid citrus juices and acids. This is like the 5th time we're seeing this. You're going to teach them perennial hygiene. Teach them to wash from front to back. Teach them to stay away from tubs and bubble baths. Avoid foods that cause alkaline acid, produce alkaline environment. Citrus juices and acids. Guys, notice this information keeps repeating itself over and over and over again. Tell them to take the drug with food or meals to reduce GI upset. Teach them the importance of increasing fluid intake, including the use of cranberry juice. Key points. Urinary tract anti-infectives destroy bacteria in the urinary tract. Urinary tract specific antibiotics prevent bacterial reproduction and causes bacterial cell death. Hygiene measures, proper diet, and extra hydration are activities that help decrease the harmful bacteria in the urinary tract. All right, we're switching gears. Everything we were talking about were anti-infectives, right? Now we're going to talk about antispasmodics, drugs that prevent those spasms of the muscles of the bladder, okay? Urinary tract antispasmodics blocks the spasms of urinary tract muscles caused by various conditions. The antispasmodics that are available include the anticholinergics, they give you the list of drugs, and the beta agonists, Myrbegron. So make sure you guys know this list. Therapeutic actions and indications of the antispasmodics. Irritation of the urinary tract leading to muscle spasms also occurs in patients with neurogenic bladder. You guys are going to learn that in med-surg when you do the neuro portion. These spasms lead to uncomfortable effects of dysuria, which is pain or discomfort with urination. Urgency, when you feel like you have to go, like right now, you're going to go on yourself. Incontinence, when you cannot hold it, right? Nocturia, that nighttime urination. And suprapubic pain, that pain that you have like right over where your bladder is located. The urinary tract antispasmodics relieves these spasms by blocking the parasympathetic activity and suppressing overactivity, which leads to relaxation of the detrusor and other urinary tract muscles. It relaxes those muscles. It prevents them from spazzing out. Because the parasympathetic system uses acetylcholine to cause its effect, these drugs are called anticholinergic drugs. What did I write here? Remember poem. Okay, so a poem to remember for the anticholinergic drugs, those adverse effects. Can't see, can't spit, can't pee, can't. Okay, can't see, blurred vision. Can't spit, dry mouth. Can't pee, urinary retention. Can't, constipation. Can't see, can't spit, can't pee, can't. Okay? You guys know what I'm saying. Trospium. Trospium, this is a new drug in this group. It's specifically indicated for the treatment of overactive bladder. That's when that bladder has all those spasms, right? With symptoms of urinary incontinence, urgency, and urinary frequency. Mirabegron, this is the newest drug for treatment of an overactive bladder and incontinence. It's a beta agonist and it stimulates the sympathetic nerves in the bladder, which leads to detrusor muscle relaxation. But look at this. It does not have the anticholinergic effects seen with the other drugs, but it does have stimulatory sympathetic effects that can cause increase in blood pressure, heart rate, etc. Remember that S in the sympathetic stands for speeding up, right? So it speeds up the heart rate, it brings up the blood pressure. So that's something that you guys need to understand. What did I write here? So for that Mirabegron, you do need to make sure you're watching that patient's blood pressure because we don't want that blood pressure to go out of the normal limits. Remember, your blood pressure is what? 90/60 to 140/90. Anything more than that, that patient's hypertensive. We don't want to put that patient in a hypertensive state. Yes, ma'am. I said, watch out for HTN. Watch out for the hypertension. Contraindications and cautions for the antispasmodics. It's contraindicated if the patient has any allergies to them, if they've had pyloric or duodenal obstruction or recent surgery. Look at this. Here's why. Because the anticholinergic effects can cause serious complications. Think about it. Did I not just tell you with the anticholinergics, you can't see, you can't spit, you can't pee, you can't. So with that last part where you can't, doesn't it make sense? Why would you give that to a patient who has pyloric or duodenal obstruction? They already can't. Why would we give this to them? It makes sense, right? We're not going to give it to them if they have obstructive urinary tract problems because that can make it even worse. Remember, this causes muscle relaxation of the bladder. What else? And this is on NCLEX. You need to know this. Glaucoma, myasthenia gravis, acute hemorrhage. Why? These could all be exacerbated by the anticholinergic effects. Renal hepatic dysfunction, if she's pregnant, lactating, and remember that drug Begron, it should be used with caution in anybody that has hypertension because it can cause what? The blood pressure to go up. So we have to be very careful if this patient already has a diagnosis of hypertension. I know I told you every hour I'd give you a break, but I lied to you because it's almost 12 and I'm letting you guys go to lunch at 12. So let's keep going. 20 more minutes. Just hang out with me, okay? Adverse effects. Adverse effects of anticholinergic urinary tract antispasmodics are related to the blocking of the parasympathetic system, and they include, you need to know these adverse effects: nausea, vomiting, dry mouth, nervousness, tachycardia, vision changes. Flavoxate is associated with CNS effects such as blurred vision, dizziness, confusion, that makes it less desirable to use in certain patients, such as the elderly patients or patients with neurological problems. Let me tell you why. Across the board, no matter what drug we're talking about, we're always going to use it cautiously in elderly patients. Number one, the elderly patient, their kidney's not working the way it used to. It's just wear and tear of the body. The kidney's responsible for getting rid of the drug. So the kidney's not working the way it used to. They're at risk for toxicity because they're going to have a buildup of that drug, right? Here's another reason. The liver is not working the way it used to. The liver is responsible for metabolizing that drug, letting that drug break down so it can get excreted. So if the liver is not working the way it used to, they're at risk for toxicity of that drug, right? Third reason, the geriatric population, they tend to lose their sense of thirst. You have to constantly remind them to take sips. So they tend to be dehydrated. So that means whatever drugs they're on tend to what? Be concentrated in their body because of the dehydration. All right? Oxybutynin has numerous anticholinergic effects making it undesirable with certain conditions or situations that might be aggravated by decreased sweating, urinary retention, tachycardia, and changes in GI activity. That looks like a beautiful select all that applies to me. Mirabegron stimulates the sympathetic nervous system and may cause hypertension and urinary retention. How many times have we seen this? That is going to be a test question. When the patient's on mirabegron, you better be thinking about that blood pressure, making sure that you assess their blood pressure. Drug-drug interactions. Decreased effectiveness of phenothiazines and haloperidol, that's the Haldol, has been associated with combination of these drugs with oxybutynin. If derifenacin or fesoterodine is combined with antifungals or antiviral agents, there's a risk of toxic effects. The dose of derifenacin or, I'm so annoyed right now, fesoterodine, thank you, has to be reduced. There's a risk for increased QT interval and serious cardiac arrhythmias if sulfonefacin, I just killed that word, but you see it, is combined with other drugs that prolong QT intervals, such as antihistamines and antipsychotics, like the Haldol, okay? Mirabegron should not be combined with drugs that are metabolized by the CYP2D6 system, as it inhibits, it stops that system. Digoxin. Digoxin should be started at a lower dose in patients that are taking mirabegron, and the patient should be monitored very closely. All right, let's look at the nursing interventions for patients who are taking urinary tract antispasmodics. Again, we're going to assess them for any allergies to that class of medication. We're going to make sure that they don't have any disorders such pyloric or duodenal obstruction or other GI lesions or obstructions of the lower tract. Make sure they don't have a prostatic hypertrophy. We'll make sure they're not pregnant, they're not lactating. We're going to assess the urinary elimination pattern. This is on NCLEX, make sure you know it. You're going to assess for ophthalmological examination, including intraocular pressure. Their eyes need to be checked. Make sure that they don't have intraocular pressure. Why? They're risk for glaucoma. The test for glaucoma is, the test they use is tonometry, okay? And that pressure, the normal range is 10 to 21. Implementation rationale. Look at this. This is the second time we're seeing this, guys. Arrange for an someone pronounce that word for me. You guys see it. I'm not even gonna try. Eye exam, how about that? Arrange for an eye exam at the beginning of therapy and periodically during long-term treatment to evaluate the drug effects on the intraocular pressure, so it can be stopped if intraocular pressure increases. Page 916. If they have GI upset, give it with food. You're going to encourage fluids. Offer frequent sips of water or use sugarless hard candy to alleviate dry mouth. That's important. Remember, can't see, can't spit. That can't spit is a dry mouth. So to help relieve that dry mouth, you're going to tell them to drink water or sugarless candy. Why sugarless? Because we don't want to turn them into a diabetic, right? Before we know it, they got high blood glucose and they'll say it's your fault. You told me to chew gum. You told me to suck on candy. No, I told you to chew sugarless gum, to suck on sugarless candy. All right? So it's very important, the sugarless. You're going to monitor the urinary output, institute safety precautions if the patient experiences CNS effects, why we want to prevent them from injury. Again, fluids, sugarless hard candy or gum. Teach them dangerous signs and symptoms to report immediately. Appropriate perineal care, such as wiping front to back, wearing cotton underwear. Don't take bubble baths. Don't take tub baths. All right, urinary tract analgesics. Remember, analgesics just decrease pain. They don't do anything to the pathogens, okay? They relieve pain. Pain involving the urinary tract can be uncomfortable and lead to urinary retention and increased risk of infection. The agent phenazipridine is a dye that's used to relieve urinary tract pain, and that is on NCLEX. NCLEX, it will test you to see if you understand that it's an analgesic and not an antibiotic, not an anti-infective. Therapeutic actions and indications is used to relieve symptoms such as burning, urgency, frequency, pain, discomfort related to urinary tract irritation from infection, trauma, or surgery. Contraindications and cautions. Obviously, we're not going to give if the patient has any allergy to that medication. If they have serious renal dysfunction, if they're pregnant, if they're lactating. What about adverse effects? GI upset, headache, rash, and this is important. This is on testing. Reddish orange coloring of the urine and staining of the contact lenses, all of which is related to the drug's chemical reaction in the system. You have to teach that to the patient, otherwise they're going to freak out. You have to tell them your urine will turn in reddish orange color. You have to tell them if you're wearing contacts for the time that you're on this medication, you need to wear glasses because it will stain your contacts. It will stain your underwear, okay? Because that dye will come out of all bodily secretions, tears, vaginal secretion, so you have to teach it to them. Drug-drug interactions. The risk of toxic effects of this drug increases if it's combined with antibacterial agents used for treating UTIs. And usually, unfortunately, we give this together, right? Because the reason the patient even has the pain is because of the infection. If this combination is used, this medication, which is an analgesic, should not be used for longer than 2 days. All right, nursing interventions for the patients that are on the urinary tract analgesics. We're going to assess them for allergy, renal insufficiency. We're going to check them for pregnancy, lactation. We're going to do a physical assessment on them. We're going to inspect the skin. We're going to check the sclera for evidence of possible jaundice. What organ are we concerned about? We want to make sure they're not having issues with liver. Very good. We're going to assess urinary elimination patterns. We're going to do a urine culture and sensitivity before or after we give antibiotics. Before. Very good. Implementation rationale. Warn them that the urine can turn a reddish brown color. It can stain fabrics such as their underwear. If they wear contact lenses, they need to wear glasses because it can stain their contact lenses. You're going to urge the patient to discontinue the use of the drug and contact his or her healthcare provider if the sclera or skin becomes yellowish. This is a sign of drug accumulation in the body and a possible sign of hepatic toxicity. The liver's in trouble. It's not metabolizing the drug the way it's supposed to. You're going to teach them about possible discoloration of the urine, reddish brown. How many times have we seen this? And measures to prevent or reduce the risk of recurring underlying problems such as urinary tract infections. All right, guys, this stuff is very important and I don't want to rush through it because it's stuff you need to know. So we'll stop here and next week we'll continue with bladder protection.